Good evening, everyone. It's an absolute pleasure to welcome you all to this special pre-conference webinar, Regenerative Medicine in Clinical Practice, hosted by Trivandrum Physiatrist Club, in anticipation of the upcoming conference, Get Set Rehab. I'm delighted to see many of you joining us today as we kick off what promises to be an engaging and insightful event. I'm Dr. Sindhuja NS, and I work as a physiatrist in health services, and I'm honored to serve as your host for today's session. As members of the physiatric community, we recognize the importance of collaboration, education, and innovation in our field. This webinar serves as a testament to our commitment to advancing rehabilitation medicine and improving patient care. The Get Set Rehab conference, which is just around the corner, promises to be an enriching experience filled with engaging discussions, expert insights, and valuable networking opportunities. But before we embark on that journey together, today's webinar offers us a chance to come together as a community to prepare, to exchange ideas, and to set the stage for what lies ahead. A word about World Down Syndrome Day. World Down Syndrome Day, observed on March 21st of every year, is an opportunity to raise awareness and advocate for the rights, inclusion, and well-being of people with Down syndrome. On World Down Syndrome Day, we physiatrists joined with the efforts to raise awareness, promote inclusion, and celebrate the unique abilities and contributions of individuals with Down syndrome. By advocating for their rights and providing compassionate care, physiatrists help empower individuals with Down syndrome to reach their full potential and to thrive in society. Now, coming to the topic for today. In recent years, regenerative medicine has emerged as a promising field within PM&R. In the context of physiatry, regenerative medicine techniques may be used to enhance the body's natural healing processes and promote tissue repair in patients with conditions such as chronic pain, sports injuries, or degenerative joint disease. Incorporating these advanced techniques into the treatment plan helps patients recover from injury or chronic conditions more effectively. It is with immense pleasure that I introduce our esteemed speaker for today's pre-conference webinar, an extraordinary physiatrist whose dedication extends beyond patient care to nurturing the next generation of professionals in our field. Dr. Padmakumar G, Assistant Professor at Department of PMR, Medical College, Trivandrum. Dr. Padmakumar stands at the forefront of interventional physiatry, bringing to the table a dynamic blend of enthusiasm, expertise, and a deep-seated commitment to advancing rehabilitation medicine. Please join me in extending a warm welcome to our esteemed speaker, Dr. Padmakumar. Shall we start, sir?
Yeah, sure.
Over to you, sir.
Okay, thank you, Sindhuja, for the lovely words you have spoken. Thank you very much. So I will start with my topic. Today, good evening to all of you. Today I will be speaking on regenerative medicine in clinical practice. Yeah. So I'll start with the introduction. And first, a few words about healing. It is a complex process of orchestrated reaction and interaction with goal of restoring structure and physical properties to the damaged tissue. You have three phases of healing. One is the inflammatory phase, which extends up to 1 week, and then followed by the proliferative phase, which extends to around 4 to 14 days, and remodeling phase, which may extend from 8 days to a year. Now, during this, the initial inflammation phase, after an injury, you have hemostasis, which can be achieved with vasoconstriction, platelet aggregation, and activation of the coagulation cascade. And here, the platelets will start to release the cytokines and the growth factors. Cytokines will act on hemopoietic cells to control the immune responses, and growth factors act on non-hemopoietic cells to modulate the healing response. Inflammatory mediators also come into play. Neutrophils clear the cellular debris, and phagocytosis will be started by the macrophages, which clears the area and allowing the cell migration in the extracellular matrix and recruiting fibroblasts. Then the healing cascade will move on to the proliferative phase, where you have angiogenesis with formation of new capillaries, and this is led by the fibroblasts and epithelial cells. And there is also vasodilation and increased blood flow coming in, and fibroplasia happening. Finally, in the maturation and remodeling phase, there is strengthening of the extracellular matrix, where the preliminary extracellular matrix will be replaced by organized matrix made of stronger fibrils, and there is also production of collagen in an organized cell. With this introduction, I will move to my topic, which is what is regenerative medicine. Now, this is defined as the process of replacing or regenerating human cells, tissues, or organs to restore or establish normal function. Now, this can be done by stimulating the body's own repair mechanism or by replacing damaged tissues by tissue engineering. Now, there are a variety of options for regenerative medicine. You can do stem cell therapy, there is tissue engineering, there is biomaterial, regenerative pharmacology, transplantation, etc. First, we will consider the stem cell-based therapy. Stem cell, as we all know, are defined as undifferentiated cells found throughout the body that have unique ability to differentiate into specialized cells. And the promise of stem cells in regenerative medicine is huge. It spans across specialties and through a multitude of diseases. So I will be speaking on mainly on musculoskeletal conditions which are affecting our body. And the stem cells can be differentiated according to their differentiation and according to their origin. According to differentiation, it may be totipotent, pluripotent, multipotent, unipotent, and oligopotent. According to the origin, it may be from the embryo, fetus, infant, or from the adult. Now, this person, Dr. Yamanaka, received the Nobel Prize in 2012 for his discovery of induced pluripotent stem cells by introducing genes for 4 factors. He was associated with the Kyoto University of Japan, and induced pluripotent stem cells means that they are adult stem cells, actually like skin cells, which have been genetically reprogrammed back into pluripotent state. And they are capable of becoming one of the many types of cells inside a patient's body. This will enable the development of unlimited type of specific human cells needed for the therapeutic purpose. We also consider one other thing, which is the multipotent stem cells, which are currently used in nowadays. These are multipotent stem cells can differentiate into those closely related family of cells. Mesenchymal stem cell is one such type, which can differentiate into osteoblast, myocyte, adipocyte, and chondrocyte. Stem cell therapy is defined by the mesenchymal stem cells have to follow these minimum criteria. One is that they have to be plastic adherent when maintained in standard culture conditions. They must express surface markers like CD105, 73, and 90, and should lack surface markers like CD45, 34, and 14, 79A, and HLA-DR. They should also be capable of differentiating into chondrocyte, osteoblast, and adipocyte in vitro. They must also be anti-inflammatory, anti-apoptotic, anti-fibrotic, and possess immunomodulatory effects. Now, how does a stem cell know what kind of a body cell to become? This process is called as cell fate decision. And what causes this to happen? This is the signals from inside and outside the cell from the environment, such as certain types of biological chemicals in the cell, extracellular proteins, hormones, and other materials, type of neighboring cells, the physical environment where the cell is located. These all determine how the cell fate decisions happen. Now, there are certain criteria to apply stem cells for regenerative medicine application. One is that it has to be found in abundant numbers, and it should be harvested by minimally invasive procedure with minimal morbidity. And the differentiation along multiple cell lineage pathways should be controllable and in a reproducible manner. Another thing is it should be safely and effectively transplanted to either an autologous or allogenic host and should be produced in accordance with good manufacturing principle guidelines, practice guidelines. Now, the sources for this mesenchymal stem cell is from, one is bone marrow, and the second is adipose tissue, as are the current sources for injectable musculoskeletal fractures. And bone marrow, it is aspirated from the iliac crust, and posterior superior iliac spine is found. And then this video shows is showing aspiration of bone marrow from the iliac crust after the posterior superior iliac spine is found, and it has to be slowly aspirated. The syringe is initially filled with ACD solution from the PRP tube, and the bone marrow is being aspirated. So once the bone marrow stem cells has been aspirated, the bone marrow mesenchymal stem cell will constitute only a very small portion of the nucleated cell. That is around 1 in 10,000 to 1 in 50,000 of the total nucleated cell. So it has to be centrifuged to produce a bone marrow concentrate, and this bone marrow viability and number will reduce with age and with. Now here you can see that lady is mixing the anticoagulant which was there in the tube with the bone marrow properly, and she is injecting it into the PRP tube. This was taken during one of our workshops during the last conference in Coimbatore. No, in Madras, during the Madras workshop. Sorry. So here you can see that she is injecting it into the PRP tube, and this will be sent for centrifuging, double centrifuging, and finally you can have the stem cells in the middle fragment. So another place where you can obtain is the adipose-derived mesenchymal stem cell. Now here you obtain it by liposuction, and it is isolated from the stromal vascular fraction of the homogenized adipose tissue, but this has a higher density per unit volume of tissue and is able to proliferate in the culture more quickly. The effects of stem cell, one is plasticity. It has good capacity for self-renewal and cell potency, and there are trophic effects which will modulate the synthesis of proliferative, pro-angiogenic, and regenerative molecules. And then there is immunosuppression, which by which it will inhibit the T and T lymphocyte activation and proliferation by inhibiting the production of inflammatory cytokines. Now, stem cell, coming to stem cell application. Now, it is widely accepted only in 2 or 3 broad medical indications. One is a handful of blood disorders, another is to help some of the burn victims. But stem cell bone marrow injection has been done for articular cartilage defects, and there was a study done by Goldring and colleagues where percutaneous injection into affected knee joint has demonstrated benefit at 24 weeks, and there was he also showed in MRI that there was significant increase in cartilage and meniscus volume. And the patient satisfaction was also 92%, and 95% of the patients said they would recommend this procedure to a patient. Now coming to the cost of stem cell therapy. The FDA is cautioning the patients regarding the hefty fees and the hype surrounding stem cell therapy. And the large price tag is said to be a major red flag. Now, I searched the internet and found that one firm in India has offered the cost of stem cell at $3,000 as compared to $15,000 in US. And along with this, you have an trip to inclusive trip to the Taj Mahal also along with it. So it is also there. Medical tourism is also booming along with it. And the adverse effects, the formation of tissues in unwanted sites, potential tumor development is also there. Peter et al. In a study found after 844 intra-articular procedures, he found only 4 serious adverse effects. One was bone marrow aspiration site infection, 1 pulmonary embolism, and 2 tumors. And most of the other adverse effects were like pain, swelling, urticaria, and transient transaminase and tingling at the site of infection. Now, coming to the evidence. This is a meta-analysis of adipose tissue-derived cell-based therapy for treatment of knee osteoarthritis. And a comprehensive literature search was done in 4 databases, and 11 adipose mesenchymal stem cell studies were found, and 7 stromal vascular fraction studies were selected. Only 5 were RCT, and the results showed statistically significant improvement in Bomax scores in both the groups for a follow-up period of 2 to 24 months. And adverse effect, as to the adverse effect, 1 study reported angina in 1 patient, and 2 studies reported pain and swelling in injection site for 2 patients and 1 patient respectively. This is a cell-based therapy review article where treatment for sports injuries in upper limb was considered, and 22 studies were included in this review, out of which 16 referred to rotator cuff pathology and 6 was epicondylitis. And in the rotator cuff pathology, bone marrow concentrate showed the most promising results with improvement in functional scores and fewer complications. And as to the epicondylar tendinopathy, phenotypes have showed a more promising result with clinical and imaging scores, and even the imaging score which was maintained up to 5 years post procedure. However, in the RCTs, the effect of magnitude of cell therapy was only small to medium. And this actually highlights the need for high quality randomized studies before we can actually recommend cell-based therapies for treatment. Next, I come to growth factor-based cell therapy. First one is platelet-rich plasma, which is being done left and right for almost a lot of procedures. Here in Trivandrum PMR department, we do it for rotator cuff injuries, we do it for osteoarthritis. So PRP is defined as plasma containing platelet concentration of around 3 to 8 times over the waistline. Ideal concentration is said to be around 1.5 into 10 raised to 6 platelets per microliter. And there are different types of PRP. One is pure PRP, another is leukocyte with PRP, and then there is pure platelet-rich fibrin and leukocyte and platelet-rich fibrin. Now, all these procedures, they are done in different techniques I use for extracting these type of PRP. Pre-procedural instruction which should be given is patient should stop NSAIDs for at least 3 days prior to procedure, and if there is antiplatelet medication, if it is not contraindicated, it has to be stopped for at least 5 days before the procedure. And another thing is viral markers has to be checked, because otherwise you may end up in litigation, unnecessary litigation process in the later. PRP preparation requires around 15 to 100 ml of whole blood, which can be obtained by peripheral venipuncture, and then it is sent for centrifuging. The centrifuging method can be either be a single spin method or a double spin method, and the platelet can also be activated using calcium chloride or thrombin to release the growth factors from the endocrine. Now there are two techniques. One is the double spin technique and the single spin technique. In the double spin technique, you can, the first spin is done at 200 Gs for 12 minutes, and the second spin is done at 1600 Gs for 8 minutes. Now, there are different protocols which people follow. Some do it for 20 minutes, like that. But in Trivandrum PMR, we do the single spin technique. It is done at 3200 RPM for 15 minutes with a high platelet and high WBC solution is obtained. And the lower 1/3 is PRP, and the upper 2/3 is platelet poor plasma. For pure PRP, if you require, after the first spin, transfer the upper layer and the superficial buffy coat into an empty tube, and the second spin is done. And then you can have the lower 1/3, which will be the PRP, along with the platelet deposit, which is there underneath the tube. For leukocyte-rich PRP, transfer the upper layer, the entire buffy coat, and a few RBC. Now, post-procedural care. This is also a very important part of the process. PRP can cause pain flare for a few days. The patient should be warned earlier itself, advised to wait for a minimum of 3 weeks before reassessing. And post PR procedure, the joint should be used gently, and joint ROM exercises, range of movement exercises, and close time teaching exercises can be started once the pain has subsided and from the next day of the procedure. And proper rehabilitation using correct protocol is absolutely necessary. Now, my professor used to say that proper patient selection is very much important as far as any procedure is concerned, and also that post-procedural care is more important, if not more important than the actual procedure, because you will get the good results only if the post-procedural care is good. So proper rehabilitation is also very much essential. Just taking PRP alone is not enough. Do not use NSAIDs for 7 to 10 days after procedure. If necessary, if the patient is having pain or something, icing and paracetamol 1 gram can be given as SOS. And how the PRP will act. The platelets, once it is activated at the site of injury, will release the growth factors like platelet-derived growth factor, vascular endothelial growth factor, endothelial growth factor, and all those things. And this will act on the growth factor receptors, which will signal proteins and transcription factor and lead to proliferation and differentiation of the cell. Now, coming to the clinical application of PRP, can be used in rotator cuff tears, patellar tendinopathies, knee osteoarthritis, lateral epicondylitis, hamstring injury, etc. And this is a procedure, and this is an ultrasound guided shoulder PRP injection. You can see which is done for rotator cuff tendinopathy. This, what you see here, is the supraspinatus tendon, which is attached onto the greater tuberosity. And the injection is given in the area above the tendon, which is the bursa. And we give it in a slightly different approach, a bit more anterior approach in Trivandrum Medical College. You can see the PRP flowing in onto the subacromial state. Now, coming to evidence with regard to the PRP injection. First, we consider the effectiveness of PRP in case of knee osteoarthritis. This was a meta-analysis of RCT. Around 21 trials were included in the meta-analysis, and the results showed clinically important benefit for pain relief when it was compared with intra-articular saline and corticosteroid injection. So the conclusion was PRP is beneficial for pain relief and functional improvement in osteoarthritis knee. But the thing is that no conclusive evidence was obtained when it was compared with hyaluronic acid. We also give hyaluronic acid injections, and there is a dilemma as to whether to give hyaluronic acid in osteoarthritis patient, knee osteoarthritis patient, or whether to give platelet-rich plasma. So I found one study where RCT, which compared the efficacy of hyaluronic acid and PRP. This was done in 150 patients with ONE, and the result came back as WOMAC subscore for pain declined in first 1 month for both the hyaluronic acid as well as PRP. But the thing is that on continued follow-up, this began to decrease, and the scores worsened and reached inferior to baseline in the hyaluronic acid group, whereas in the PRP group, it was significantly better up to 12 months. And this was also reciprocated in the IKDC score. This is International Knee Documentation Committee score, and this was the same with regard to these scores as well. But on MRI, increase in cartilage thickness was not observed in either of the two groups. And this study also mentioned that the application of PRP with an absolute count of 10 billion platelets in a volume of 8 ml. So this is a huge volume of platelets which is being given, which we do not achieve with normal centrifuge. Here they have used special 1 micron flushback filters along with WBC filters to obtain this much high concentration. So we don't use in our setup, we don't use such high concentrations, but we do get good results in most of the patients which we have treated. And the patient response, satisfaction is also very good. Now, this was a study, original research article, where the size reduction in partial thickness tear in supraspinous tendon was compared when with PRP was compared to corticosteroid injection. And in either group, there were 14 and 15 patients in PRP and corticosteroid group respectively. And the tear size was measured coronally and sagittally by MRI, and a repeat MRI was done after 6 months. And they said the study found that there is significant reduction in tear size noted with improved functional scores in PRP group as compared with the corticosteroid group. There are two studies in cases of lateral epicondylitis. Why I am taking these two cases in particular is that we give a lot of PRPs for rotator cuff injuries as well as lateral epicondylitis. So the first study was a single injection of PRP, which showed that on short-term follow-up, it was better than triamcinolone or placebo. The second study was done in Netherlands on 100 patients. This was a double-blind RCT, which was done with a 1-year follow-up, and there was reduced pain and improved function, which exceeded that of corticosteroid. Contraindication, side effects, and adverse effects. Actually, PRP is an autologous treatment, so it is inherently safe. There is no concern regarding transmittable diseases. And adverse reactions which was reported was mostly pain and effusion, which disappeared in a week's time, and other reported adverse effects were syncope, dizziness, headache, gastritis, etc. But to be frank, we just have had pain, effusion, or something like that for patients, which disappeared by around a week in most of our patients. Now, next coming to prolotherapy. Prolotherapy was started off as sclerotherapy, which was injection of proliferant to stabilize joints and ligaments, which were there surrounding joints. Now, it has been transformed as prolotherapy, where you inject a proliferant in order to cause an osmotic gradient with the target tissue, leading to cell desiccation and promoting healing via the inflammatory cascade. 3 solutions are used. One is hypertonic dextrose via osmotic rupture which will act via osmotic rupture of local cells, and dextrose also acts as a signaling agent in tendon repair. Another one is phenol glycerin glucose, which acts via the local cellular irritation. Another solution is sodium morphate via chemotactic attraction of inflammatory medium. Now, who is a good candidate for prolotherapy? On history, you can use it on tendinitis, in patients having joint hypermobility. It may be due to trauma or generalized hypermobility or overuse tendon, overuse-induced hypermobility, and also in cases of osteoarthritis. But ultrasound guided prolotherapy has been used in a number of places. I personally prefer to use it for epicondylitis, lateral epicondylitis, medial epicondylitis, or in cases of where you can have ATFS, that is anterior talofibular ligament injuries, or medial and ulnar collateral ligament injuries around the. Now, the technique will be like small gauge needle is used. You usually use 26 gauge needle, and it is advanced in and around the tissue. And we use it in a stenotomy-like action, and small aliquots around 0.5 ml per site of dextrose solution is put. Hypertonic dextrose solution is put, and multiple sites are injected along the structure which is in question. And we also give perineural injections to target superficial nerves, which can cause neurogenic inflammation. And the patient may have post-injection soreness or mild to moderate pain owing to an induction of inflammatory events. Now, the pre and post procedural care, NSAID should be withdrawn 2 days prior to the injection and for up to 7 to 10 days post-injection. You can give acetaminophen if required, and resting the affected part after some impact and repetitive use daily is necessary, and the treatment is prolotherapy is safe, inexpensive. Now coming to the evidence regarding prolotherapy, it was given for lateral ankle ligament injuries in elite athletes. This was a case series where ATFL injuries, like the one where I used to give, 9 elite athletes underwent prolotherapy, and the result was like when comparing with prolotherapy and without prolotherapy, the return to play time was reduced to 45 days when prolotherapy was used, as compared with 56 days when prolotherapy was not used. So the conclusion of the study was that prolotherapy is a safe alternative for ATFL injury in elite athletes. And efficacy of prolotherapy for lateral epicondylitis. This was a pilot study which was done. This was a double-blind RCT, 24 patients with refractory lateral epicondylosis was treated, and the results showed improved pain score, grip strength, extension strength at 16 weeks, which was maintained up to 52. This is a study, comparative study of prolotherapy using a dextrose solution, which we use in our department for tennis elbow. And around 260 patients were divided into 2 groups, where prolotherapy was compared with steroid injections, and prolotherapy using dextrose had better functional outcome and long-lasting effects in the management of tennis elbow when compared with steroid. That was the finding. This is a meta-analysis for ONE, using prolotherapy in ONE. Now, here, 11 articles met the search criteria, and the risk of bias was low in only 2 studies. But the finding was that prolotherapy was no different from PRP when pain subscale was compared at 6 months point of time. But the prolotherapy was inferior to PRP on the stiffness subscale. And the recommendation or strength of recommendation was B, that is moderate evidence for dextrose prolotherapy was there, and it is recommended to be safe with no major side effects. Now we come to the last part of the presentation, that is tissue engineering. This is a collagen meniscal implant which is used in surgical procedures for reinforcement and repair of soft tissue injuries of meniscus injuries. Now this is a reabsorbable scaffold which that is replaced by patient's own soft tissue. And this is not a prosthetic device, and it is not intended to replace any normal human structure. So this is just a scaffold for the patient's tissue to grow. And the procedure is like irreparable. If there is an irreparable meniscus tear, you will prepare the site, and the CMI is sutured in place. And finally, it will look like the meniscus of the base. And actually, I was fortunate enough to be part of a rehabilitation team which did a meniscal CMI, collagen meniscal implant procedure, and the patient was very happy with the results of the procedure. So this is a study, clinical trial, where 8 patients underwent arthroscopic replacement of collagen meniscal implant for irreversibly damaged meniscus. The relook arthroscopy revealed on visual observation that there is preservation of the joint surface, base joint surface, and the radiograph confirmed that there is no progression of degenerative joint disease. To conclude, the stem cell has shown promise, but there is a lot of lack of standardization in the methods used, the culture, and the cell type. This makes a firm conclusion to be drawn from the studies as difficult. PRP has shown good results in our setup also in cases of rotator cuff injuries and moderate grade osteoarthritis. But in studies, one study has recommended an absolute count of 10 billion platelets, which is crucial in PRP formulation to have long sustained chondroprotective effects for up to 1 year in moderate knee OA. And prolotherapy is useful in cases of ligament injuries and enthesopathy. I have used it in a lot of cases of ATFL injuries which are coming to the department, and the patient have found good patient satisfaction and a reduction in pain scores with these patients. They also use prolotherapy for tennis elbow, golfer's elbow, and the like. These patients also have good growth. Another one is the tissue engineering technique, which is to develop a reabsorbable collagen scaffold that supports ingrowth of new tissues and eventual regeneration of the lost meniscus. Thank you.
Thank you, Dr. Padmakumar. On behalf of everyone present here, I want to extend our heartfelt gratitude for sharing your expertise with us today. Your comprehensive knowledge of stem cell therapy, PRP therapy, prolotherapy, and tissue engineering technology has provided us valuable insights into these groundbreaking treatments and their potential applications in clinical practice. The visuals, including the videos and pictures you shared, added valuable depth to the discussion and helped us better understand the potential of this treatment. Thank you for generously sharing your time and expertise with us. Now the topic is open for discussion.
I think, Sindhija, there are a few questions in the chat box. One is from Dr. Anil. Will you be using local anesthetic? How painful will it be? It will be as painful as any other injection procedure. Because, and one other thing is that we are using 26 gauge needle. So it is of a smaller size than the regularly used needle size. And of course, we will be using local anesthetics before injection. Local anesthetics are used. So I think that should clear your doubt. There is another one from Dr. John. Is prolotherapy the same as dry needling done by physiotherapy? No, it is not the same as dry needling. Dry needling, we usually refer to it as for trigger point injections. We use it. Sometimes it is used by physiotherapy, but we use it along with local anesthetics, and it is not the same as prolotherapy. Prolotherapy is totally different. This is a sclerosing agent. Dextrose is used along with this.
Shall I interfere?
Yeah, sure.
Dr. Anil sir, are you here? Anil sir? Hello, Anil sir? Are you here? Can you hear me? Okay, I think Anil sir is not responding. So we'll go to the next question. Comment on the use of opioids like tramadol as oral or injection in the case of post-PRP injection pain.
Post-PRP injection pain is actually very little. I mean, most of the time, most of the patients don't have any pain. And the thing is, paracetamol 1 gram is more than enough. And if it is, if the patient, most of the time it is just lasts for one day or 2 days. It is very rarely lasts beyond that. And in very small percentage of patients will have post-PRP injection pain. So if you want, you can use opioids, but I would prefer paracetamol. Usually recommend paracetamol 1 gram.
Okay. Can I talk?
Yeah,
yes,
sure,
yes, madam, please, madam.
So let me first congratulate the Geriatric Society of Trivandrum for their regular activities. So എനിക്ക് പറ്റാറില്ല അതിന് പങ്കെടുക്കാൻ പറ്റാൻ you really need a congratulation. പക്ഷേ Dr. Padmakumar, and this is a very interesting topic and you have explained it so well. പക്ഷെ എനിക്ക് my doubt is under prolotherapy usually we put the stem cell, bone marrow, PRP ഒക്കെ നമ്മൾ അതിന്റെ അടിയിലാണ് കേട്ടുകൊണ്ടിരുന്നത്. So do you keep it as a separate entity, prolotherapy എന്ന് പറയുന്നത്, only for dextrose?
No. I don't keep it as a separate entity. I didn't mean to put it down or above any other procedure. It is just another procedure because I was following a set pattern, like cell-based therapy I was putting up, followed by the PRP and prolotherapy. That's all. Prolotherapy actually, in the earlier days, it was sclerosant therapy. It is called as sclerosant therapy in the early part of the phase, where it was actually used for strengthening of joints, where there was laxity of joints and ligaments. It was there. Now the less irritant things have been used, And the dextrose is which is used, the hypertonic dextrose. That is, we use 25% dextrose along with local anesthetic, and this actually helps in promoting growth factors on the said to help growth factors come to the area and help in healing of the area. But basically, I feel that it is more of fibrosis coming in and strengthening those ligaments. That is why I have a logic of using it in places where there is ligament injuries, and even in cases where there is enthesis is involved, like in cases of tennis elbow or golf.
What all you have used other than dextrose? You have used PRP?
Yes, we are doing PRP regularly. I think close to 800 or around 1,000 patients have received a PRP from us in different places like shoulder or knee, even for tennis elbow.
How many sittings you give?
Usually we give the first sitting. After the first sitting, we wait for the first 3 weeks for the results to appear. And if it is required, we do second or third session, only after that. And along with this, I must stress one point: rehabilitation is an absolute necessary thing, because you have to do exercises, because there will be wasting of muscles around the joint, and this can cause a lot of morbidity for the patient. So it is absolutely essential that they do exercises in a proper graded fashion and gradually increase the exercise intensity. Because if they start doing exercise all of a sudden, it may be, the patient may find pain and then they won't do the exercise. So it should be graded and increased in a timely fashion and progress. Actually, we have got good results even in cases where there was complete tear of rotator cuff, both functionally and pain.
It's a wonderful technique anyway.
And
stem cells, it has to come. Is it being done
yes,
in
Brother?
Is it being done, stem cells? Do you know?
I don't know. Frankly, I've seen actually during the last, there was one workshop which was conducted in Chennai. So there was a doctor there from, I think, I don't know which area, Madurai, I think. And he was doing stem cells, but that was from bone marrow concentrate. But, it is like 50-50.
We have heard a lot from Sasikumar sir also.
Yes. Sasikumar sir is an expert in prolotherapy.
Yes. And we had a lot of workshops also.
And I too have learned from him, actually. Prolotherapy, I learned from him. There is another question from Deepa Arun. How long after PRP can the joint be used for normal activity? It can be used from the second day itself. If there is no pain, you can use it from the second day itself. But it should not be like lifting heavy weights or beating up your kids or something like that. It should be used in for normal activity. There is one question from Dr. Frank. Any training course at medical college for students or consultants? Any books on the topic? There are a lot of books which are available. Training workshops are being conducted on a regular basis for all these procedures, both for PRP as well as prolotherapy during conferences. Another one question is there from Dr. Lajni. PRP always done under USG guidance in shoulder cases. It is better to do under USG guidance, is what I would say, because you are putting in a large volume of fluid into the tissue. You don't want, personally, I don't put it into the tendon. I put it in the bursa around the tendon, so that there is less pain to the patient post injection. It is better to do under USG.
But you do it without USG also?
No, PRP I usually use.
Not PRP, prolotherapy?
Prolotherapy, of course. without USG guidance. Prolotherapy or without USG guidance. I don't normally use USG for prolotherapy. Knee PRP, no need for any USG guidance or anything. But in case of shoulder, better use ultrasound guidance.
Sir, is Dr. Josh Sakri over here? Sakri, sir? Can you hear me, sir?
Yes.
Sir, please, sir, shall we welcome Dr. Sakri, sir, distinguished professor of Physical Medicine and Rehabilitation and a renowned expert in the field with extensive experience and passion for advancing the practice of PM&R. Please share your valuable insights on this topic, sir.
It has been an excellent presentation by Padmakumar, and Dr. Padmakumar is our expert in giving PRP in our department. So I think he has explained it much better, and we have good results from PRP for the shoulder and the knee. Thank you.
Thank you, sir. Next question. How long after PRP can the joint be used for normal activities?
Yes, I
already covered. Okay.
Yeah.
Yes.
Can use it from second day, sir.
Yes, yes.
No problem.
Any other doubts to clear?
Use it in the first day. So.
Any other doubts? Shangaram, sir? Can you hear me, sir? Shangaram, sir? Dr. Padmakumar is getting more compliments. Excellent presentation from Dr. Uma. Dr. Pradeep Kumar, congratulations.
Thank you.
Please share your doubts, opinions, and suggestions.
There is another one question from Dr. Shabana.
Dr. Shabna.
JRA affected Shabna. JRA affected elbow joint, is it beneficial? JRA I wouldn't prefer because that is already an inflammatory condition. So I wouldn't prefer to use PRP in JRA.
Okay. Dr. Lakshmi, can you hear me? Dr. Lakshmi, can you hear me? Please share your valuable insights on this topic.
Yeah, sir has already discussed it in an excellent way. And PRP is very commonly used in a department, as he has already mentioned. Both Prolo and PRP. And sir has been an important, he has played a vital role in making it such a common procedure among all of us. Regarding insights, experience PRP has been used commonly for osteoarthritis by me as well as for shoulder, and osteoarthritis knee patients has got excellent result, but we might have to repeat it maybe 3 monthly or 6 monthly, and because it does not have side effects, we do it also. Yeah, no, it is like earlier intra-articular steroids was very common. Now we hardly use steroid for osteoarthritis knee. Yes.
Thank you. Thank you, Dr. Lakshmi.
There are two more questions in the chat box. One is I think from Dr. Moedisa. She has asked, what about PRP on hemophilic units? No injections around any hemophilic joint, as far as I am concerned. I wouldn't take any needle to anywhere near any hemophilic knee joint. And one other question from Dr. Frank. Whether it is effective for cancer pain? No, I don't use. Regarding cancer pain, it is better to go for, if required, for morphine or follow the WHO pattern step ladder approach for cancer case. Or if required, we can use more.
Okay. Dr. Vipin Vijayan is here. Dr.
Dr.
Vipin
Anup
Vijayan.
Sudevan has sent a message. What is your experience with lateral epicondylitis? I've given for a lot of patients with lateral epicondylitis prolotherapy. I'm more satisfied with prolotherapy rather than, I would say, PR with regard to lateral epicondylitis. I've got good results. Yes,
Our new generation physiatrists are very enthusiastic in interventional physiatry. Dr. Vipin Vijayan, please join me. Can you hear me, Dr. Vipin?
Yes, madam. Yes, madam.
Yeah,
Madam, കുറച്ച്
yeah.
late ആയിട്ടാ join ചെയ്തത്. ഞാൻ full കേൾക്കാൻ പറ്റിയില്ലായിരുന്നു.
No problem. Please share your valuable thoughts on this topic. You are an expert in interventional
Madam,
physiatry. We all know that.
Yes, ma'am. Everybody is interested in interventional physiatry. Actually, usually steroids കാരണം PRP കുറച്ച് ടൈം കൺസ്യൂമിങ് പ്രൊസീജിയർ റിപ്പീറ്റഡ് ആയിട്ടുള്ള സിറ്റിംഗ്സും വേണ്ടത് കൊണ്ട് തന്നെ സിംഗിൾ ഫിസിയാട്രിസ്റ്റ് ആയതുകൊണ്ട് കുറച്ച് ബുദ്ധിമുട്ടുണ്ടായതുകൊണ്ട് ഞാൻ ഇതുവരെ സ്റ്റാർട്ട് ചെയ്തിട്ടില്ല. ഇൻട്രാക്ടുലർ സ്റ്റിറോയിഡ്സ് കൊടുക്കാറുണ്ട്. യൂഷ്വലി നല്ല റെസ്പോൺസ് ആണ് എനിക്ക് അതിന് ഇമീഡിയറ്റ് പെയിൻ റിലീഫിന് കിട്ടാറുള്ളത്. അപ്പോൾ ഇമീഡിയറ്റ് ആയിട്ടൊന്ന് പെയിൻ റിലീഫ് കിട്ടിക്കഴിഞ്ഞാൽ യൂഷ്വലി ഒരു തെറാപ്പി ഒരു സെഷൻ ഒരു 1-2 ആഴ്ചത്തെ സെഷനോട് എനിക്ക് കുറച്ച് നല്ല റിസൾട്ട് ഉണ്ടാക്കാൻ പറ്റാറുണ്ട്. അപ്പൊ ബേസിക്കലി ആ ഒരു ഇനീഷ്യൽ തെറാപ്പി തുടങ്ങുന്ന ഒരു പെയിൻ റിലീഫിന് വേണ്ടിയിട്ട് ഞാൻ സ്റ്റിറോയിഡ് കൊടുക്കാറുള്ളൂ. റിപ്പീറ്റഡ് ആയിട്ട് ഇഞ്ചക്ഷൻ കൊടുക്കാറില്ല. ഇഞ്ചക്ഷൻസ് ആക്ച്വലി അൾട്രാസൗണ്ട് ഗൈഡോട് കൊടുക്കണം എന്നാണ് പ്ലാൻ. പക്ഷേ ഇതുവരെ എനിക്ക് അങ്ങനെ കൊടുക്കാനുള്ള ഒരു ഇത് കിട്ടിയിട്ടില്ല. മസ്കുലോസ്കെലറ്റൽ അൾട്രാസൗണ്ട് സ്വന്തമായിട്ട് ചെറുതായിട്ട് ചെയ്ത് പഠിച്ചുകൊണ്ടിരിക്കുന്നേ ഉള്ളൂ. അപ്പൊ ഇനി കൂടുതൽ വർക്ക്ഷോപ്സും കാര്യങ്ങളും കഴിയുമ്പോൾ അതുകൂടി ചെയ്യാൻ പറ്റുമെന്ന് വിചാരിക്കുന്നു. താങ്ക് യു വെരി മച്ച്, സർ. താങ്ക് യു ഫോർ ദ ടോപ്പിക്.
Thank you,
Thank you,
Dr. Vipin. Dr. Sanjita, can you please come over? Dr. Sanjita has given a compliment to Padmakumar sir. Excellent informative talk.
Hello.
Thank you.
Dr. Sanjita,
Hello.
please share your valuable insights. Hello?
Not hello. Hello.
Yes, please carry on.
I don't have much experience in that.
Okay.
Should start, madam. Should start giving
Yeah.
all these
Yeah.
prolotherapy is relatively easy. You can just attend 1 or 2 workshops and you can
Okay.
start. It gives
Yeah,
very
yeah.
good results.
Okay.
Okay, thank you. Dr. Ansi Isaac, are you here? Dr. Ansi? Dr. Ansi is a professor at Kottayam Medical College. Dr. Ansi, can you hear me? Okay. Dr. Hafiza?
Hi.
Hi,
Thank
hello.
you. Hi, Sindhuja madam. This is, sir has given already a very good elaborative presentation. I just want to put 1 or 2 points because I do a lot of prolotherapy and PRP. This PRP is also useful in, apart from all those mentioned, also used in this degenerative tears of meniscus, these ligament injuries and all. And I usually give it as a 3 sittings of 3 weeks gap. Okay. And in rotator cuff injury and also muscle tears, other muscle tears like TA tears and all, the sports injuries, PRP is very effective. It is found to have very much effect in these groups. Also, like sir told, the prolotherapy was highly effective in ankle injuries and also unstable joints like multiple ligamental issues in knee joint, etc. Also lateral epicondylitis. That's all. And also I have given a few of cervical and lumbar degenerative, the multiple disc issues and spinal issues also, chronic issues. Even have been found to have effective in patients with multiple trigger points, chronic pain syndrome with multiple trigger points in special areas. We focus on those areas, and I used to give prolotherapy 3 to 6 sittings and have found very much effective. That's all. Thank you.
Thank you, Dr.
Dr. Hafiza is actually, I think she does a lot of prolotherapy and he's doing a lot of intervention, I think. Good.
Sir, another question from Dr. Sudhira. We rehabilitation physicians
It's not
should
a
start
question.
more.
Suggestion.
Yeah, such
That is
intervention
a
procedure.
suggestion.
Not a
Yeah,
question.
that's a suggestion. Yeah, that's not a question.
We have been telling in all conferences because in the present scenario, we have to, especially the young physiatrists, you have to start with such invasive techniques more and more because our specialty is facing a lot of competition, we know. So such invasive procedures have to be more classes has to be there, and the young physiatrist have to take up such things more. I was only giving an advice.
Yes, sure, madam. We should actually.
Yes.
Our last Trivandrum conference was named as interventional physiatry mainly to
Yes.
encourage people to start intervention.
Yes, yes.
There is one more question from Dr. Shabna. Is there any method other than PRP beneficial? Now, I don't know regarding what you were asking, but I can tell you patient selection is very much important. Any treatment, patient selection is very much important. Whether it is PRP, whether it is prolotherapy or any other treatment, patient selection is for the success of the treatment to be good there. Patient selection is important. Second, another thing is post-treatment. You have to do rehabilitation. I know a lot of places where they give PRP and just ask the patient to come back after 3 weeks, again do another PRP, after 3 weeks, again another PRP, like that. They don't do any other in between post-procedure care, nothing is given. You have to understand one thing. Once there is pain, the patient will not move the joint around, and this can result in a lot of wasting around in the surrounding muscles. So you need to do exercises. You need to build up those muscles so that your function and pain, everything comes back to normal.
I think the most important advantage we should say is rehabilitation becomes very easy after prolotherapy, not like repair or surgical repair like that.
Yes, true.
Okay. Suresh sir, can you hear me, sir? Dr. Suresh? Suresh sir, can you hear me?
So, Padmakumar, that was a wonderful talk. Please let me leave the meeting.
Sure, madam. Thank you.
It was a wonderful topic, and thank you all. Thanks for this interesting and explanatory one. So let me leave with your permission.
Thank you, madam.
Thank you. So,
Anyone wants to clear doubts?
Shall we wind up the meeting? I think if there are no more doubts, shall we wind up the meeting?
Shall we wind up or?
Yeah, sure.
Okay. Thank you all for participating in this today's webinar. I think I hope it has been an enriching experience for everyone. We appreciate your time and thoughtful participation. Thank you again for being a part of this webinar. So till we meet again, good night and take care. Bye.
Thank you. Thank you very much.
Thank you.